Today's webinar will begin in 1 minute. Welcome to today's webinar, Updates from the 2019 Conference on Retroviruses and Opportunistic Infections, Trends in the HIV Epidemic and Progress in Prevention. I would like to introduce Susan Buchbinder, MD, Director of Bridge HIV at the San Francisco Department of Public Health and Clinical Professor of Medicine and Epidemiology at the University of California, San Francisco in San Francisco, California. Welcome, Dr. Buchbinder.
Thank you so much, and welcome to all of you for joining us today. I'm going to be covering HIV epidemiology and prevention, and just as a tease for later in the month, or next month, May 21st, Tim Wilkin is going to be doing a presentation on HIV treatment and complications. So this is a reminder that you need to type in your full name and your email address, your institution. And then if you're watching with a group, please be sure to have all of the other people in the group also type in their names and institution. But only pre-registered attendees can claim CME, nursing, or pharmacy credits or a certificate of participation. If you do have any questions as the session goes on, please do type them into the chat box, and we will be taking questions if you have problems, you can type them into the chat box. If you have questions, type them also into the chat box. We have a question and answer session at the end, and to the extent possible, I'll try to also answer questions as they come up on the slides when I go through them. Next is just to remind you that IAS-USA has a new website, and the first time you log in, you'll be asked to reset your password, but please visit the website. It's got a lot of important information on it. You can get 1.25 CME credits for physicians and 1.25 hours of pharmacy and nursing credit as well for attendees. We want to thank the generous support of these supporters. We're going to be starting by asking a couple of questions just to get a sense of who's on the webinar, and so please be sure to answer the questions in the poll box itself, not in the chat box. But again, if you have questions as time goes on, please type them into the chat box and we'll take questions at the very end. We'll also have 2 pre-test questions and ask those same questions as post-test questions after the seminar, as I'll be covering those topics in the webinar itself. So let's start with the first poll question. From which geographic region are you viewing this webinar? And please type in your answers. Okay, so we have a good geographic distribution. And now we're going to ask you to rate your level of experience in the medical management of HIV infection, anywhere from 1 as a novice to 5 as an expert. Okay, and it looks like we also have a range of responses to degrees of expertise, so that's great. And as I said, what we'll be doing today is covering HIV epidemiology and prevention. This is my disclosure. And these are the learning objectives. So upon completion of the webinar, learners should be able to identify the 4 strategies for ending the U.S. HIV epidemic, explain U equals U or undetectable equals untransmittable, describe changes in STI incidence over time, and compare the efficacy of TAF FTC or tenofovir alafenamide FTC with tenofovir disoproxil fumarate FTC or TDF FTC for pre-exposure prophylaxis. So let's start with 2 pretest questions. The first is, which statement is true of a person living with HIV who is fully virally suppressed? 1 is that they can't transmit HIV through breast milk. 2 is they can't transmit HIV sexually. 3 is that they can transmit HIV sexually if they have an STI. And 4 is they can transmit through anal but not vaginal sex. Please type in your response in the poll box. Okay, great. So it looks like we're going to cover this at the end of during the seminar, and we'll ask again at the end of the seminar or the webinar. And then the second question is, which statement is true of TAF FTC? Is it superior to TDF FTC in efficacy as PrEP? Is it inferior to TDF FTC efficacy in PrEP? Is it associated with a more favorable renal profile than TDF FTC when used as PrEP? Or is it associated with more antiretroviral resistance than TDF FTC? Please answer this question again in the poll box. Okay, so now we're going to move on to the webinar. I'm dividing this talk into 5 sections. We're going to start by some presentations on ending the epidemic. Then we'll talk about undetectable equals untransmittable or U equals U, drug use, sexually transmitted infections, and then pre-exposure prophylaxis. So let's start with ending the epidemic. And we'll start with Dr. Tony Fauci's talk. He gave a special presentation at the beginning of the seminar, and I would just refer you to the CROI website where you can see webcasts of some of these talks, and I'm going to highlight some that I think were particularly compelling, and I think this was one of those that was particularly compelling. He started off by pointing out that the U.S. epidemic has stalled out at about 40,000 new infections a year without a substantial decline over the last several years. And he wrote an opinion piece actually back in January of 2016 in the Washington Post saying, no more excuses, we have the tools to end the HIV/AIDS pandemic. And what are those tools? Well, first of all, we have treatment. And as was shown in the HPTN 052 study, that randomized serodiscordant couples in 9 countries to either immediate antiretroviral treatment or antiretroviral treatment after a CD4 count dropped below whatever the country level threshold was, they found a 96% reduction in HIV transmission when ART was started early. In follow-up, after 5+ years of follow-up, they had a 93% lower risk. And most importantly, there were no linked infections when HIV was stably suppressed by ART. When somebody had an undetectable viral load in an HIV-positive partner, there were no transmissions to an HIV uninfected partner. So we know that U equals U, that undetectable equals untransmittable, and that people who are fully virally suppressed cannot transmit HIV to their uninfected sexual partner. We also know that PrEP is highly effective, and the CDC estimates that 1.1 million individuals in the United States are at substantial risk for HIV and should be offered PrEP. But we also know that there are disparities in who is receiving PrEP, and that as of the end of 2018, about a quarter of people who were potentially at risk for HIV infection had ever taken PrEP, and there probably is a smaller proportion who are currently on PrEP. So what Dr. Fauci said was, theoretically, if we accessed and put on antiretroviral therapy everyone who has HIV and provide PrEP for all at high risk of HIV, we could rapidly end the HIV epidemic. And he showed these graphs from 3 cities, San Francisco, New York City, and Washington, D.C., where there's been rapid scale-up of testing and early treatment for people living with HIV and pre-exposure prophylaxis for those who are at risk of HIV. And you can see that these curves are quite substantially different from the overall national curves of what we're seeing in terms of numbers of new infections. We're seeing dramatic declines over time. So this is important and led to some recommendations that I'll go over in just a moment. He also noted that there are geographic disparities, but also geographic concentration of the epidemic. There are over 3,000 counties in the United States, but over 50% of new infections from 2016 to 2017 occurred in just 48 of those counties, Washington, D.C., and San Juan, Puerto Rico. The majority of new infections are occurring among Black or African American and Latino men who have sex with men. And there's a high incidence among transgender individuals and people who inject drugs. And then there are also 7 mostly southern states that have a disproportionate occurrence of HIV in rural areas. And this here is a map showing those counties with the high concentrated epidemics and the 7 states with high epidemics in their rural areas. So they proposed a 4-part proposal for bringing together all of the health and human service agencies within the government to focus our efforts on reducing new HIV infections nationally. The first point is to focus initially on the high incidence geographic areas, targeting those 48 counties, Washington, D.C., and San Juan, that account for over 50% of diagnoses, and targeting those states with high rural HIV burdens. The second point is to emphasize early diagnosis, immediate treatment, and engagement in care, to really focus on rapid viral suppression. Currently, viral suppression rates are about 60%. They want to target a 90% viral suppression rate, and pointed out that HRSA's Ryan White HIV/AIDS care program has already achieved an 86% viral suppression. So we should be able to achieve that 90% viral suppression if we can get people into treatment immediately and keep them engaged in care. The goal for pre-exposure prophylaxis is to increase use by the at-risk population to at least 50%. And then finally, we want to have a rapid and overwhelming response to emerging HIV clusters. So we're going to talk about a couple of clusters that were identified later in the webinar, and the idea is to see these each episode of new infection as a sentinel event, to look for clusters, and to then go and intervene in those clusters to prevent onward transmission. So that was the U.S. epidemic, and now what we're going to do is turn to the global epidemic, and I'm going to talk to you about the POP-ART study, which was a study to see if widespread testing and treatment within these communities within Zambia and South Africa could substantially reduce the HIV infection rate. What they did is they took 21 communities, they divided them into triplets so that had equivalent characteristics. One of the communities in the triplet would then be randomized to Arm A, the second to Arm B, and the third to Arm C. And then this accounted for about 1 million individuals within these populations. And the idea was to give different interventions to the three arms and to see if you could drive down HIV infection rates. And this is what was in each of the arms. In Arm A, there was the full pop art intervention, which I'll describe in a moment, and also immediate antiretroviral treatment irrespective of CD4 count. Arm B was the full pop art intervention, except that ART was only begun according to national guidelines. And when the study began, the national guidelines did not call for antiretroviral treatment immediately upon diagnosis, but partway through the trial, that did become the norm. And so I'm going to show you that arms A and B were pretty comparable in terms of their ability to, in terms of their viral suppression rates or their antiretroviral treatment rates. And then Arm C was just to keep the current service levels at the standard of care within those communities and begin ART according to national guidelines. What they did is they sampled 2,500 individuals from each of the communities and ages 18 to 44, and then they followed them up annually for 36 months. And here's what the interventions looked like. They had these CHIPs, or community HIV care providers, that went door to door to deliver the intervention, that included HIV testing, retesting, and referral to clinic for those individuals who needed medical services, and then repeat visits to clients living with HIV. And what you can see was involved in these interventions was universal HIV counseling and testing for men who were uncircumcised and HIV negative, referral for voluntary medical male circumcision, for women who were living with HIV who were HIV positive, referral for prevention of mother-to-child transmission services, STI and TB screening, and condom use. And now I'm going to show you what they did in terms of antiretroviral treatment coverage. So they were trying to reach the 90-90 targets. As you know, 90-90-90 is 90% of people living with HIV are aware of their infection, 90% of those are on antiretroviral treatment, and the third 90 is 90% of those are virally suppressed. They wanted to look at the first two 90 targets. If you combine 90% times 90%, it equals 81%, and so that was their target level, and you can see that in the red line here. The circles were the women, the squares were for the men, and the black was for Arm A and the blue was for Arm B. So you can see that because the guidelines changed partway through, and the only difference between Arms A and B were beginning antiretroviral treatment immediately upon diagnosis, the rates of antiretroviral uptake were pretty comparable between Arms A and B. But you can also see that particularly for younger men up to the age of 40 and younger women up to the age of 30, they did not reach those 90-90 targets. And that's really of concern because we know that these young women are at high risk of HIV acquisition by these slightly older men. And here's what they found in terms of the outcome. So the overall HIV incidence rate was 1.55%. There was a 7% reduction in Arm A, which was not statistically significant, after adjusting for age category, sex, and baseline community HIV prevalence. There was a significant reduction in Arm B, a 30% reduction, which was statistically significant. And it's unclear why there were differences between Arms A and B, since, as you saw, the rates of antiretroviral uptake were pretty comparable between the arms. So there's a lot of work going on to try to tease out what it was that made a difference between Arms A and Arm B. It did, however, show if you combined Arm A and Arm B, there was still a statistically significant 20% reduction in new HIV infections in these communities compared with the Arm C communities. So what this suggests is that scaling up testing and treatment can lead to substantial reductions in antiretroviral treatment, and in new incident HIV infections. The challenge was that we didn't see a larger reduction. And what you remember is that pre-exposure prophylaxis was not part of the package. And so it may be that we really do need to add pre-exposure prophylaxis to get the really dramatic declines that we're seeing in those cities that I showed you before in New York, San Francisco, and Washington, D.C. So let's turn now to talking about U equals U. And there was an entire seminar on U equals U that I highly recommend. This was from a presentation by Neka Nicolo from the Dean Street Clinic in London. She reinforced that U equals U refers to the concept that an individual with an undetectable viral load is incapable of transmitting HIV to their sexual partners, and that reducing viral load also significantly reduces the risk of transmission to unborn babies and to healthcare workers who experience sharps or mucosal injuries. Breastfeeding, however, there still transmission can occur. There have been cases of transmission occurring that have been documented in women who are fully virally suppressed, and that may be for a number of reasons. Babies have immature immune systems. They're being exposed to really high volumes of breast milk, 150 gallons over the course of breastfeeding lifetime. They also, there are many inflammatory cells and activated target cells in breast milk. So there are reasons why it may be that breast milk can transmit HIV, but sexual contact does not transmit HIV when someone's fully virally suppressed. And this was reviewed very nicely by Pietro Vernazza, who went through all of the observational studies shown here, as well as the partner and opposites attract studies shown on the bottom, that led to, and in all of these, the rate of infection has been 0, 0, 0, 0, 0, 0, 0. Over 150,000 condomless sex acts just in these last studies alone, many more from these earlier studies. And so now the estimate is that there is 0 transmission with the upper bound of the 95% confidence interval of 0.07 per 100 person years, or 7 per 10,000 person years. What he also spoke about was that it's really difficult to prove the negative. But he cited this philosopher from 1953 who wrote, "In some circumstances it can be safely assumed that if a certain event had occurred, evidence of it could have been discovered by qualified investigators, and in such circumstances it's perfectly reasonable to take the absence of proof of its occurrence as positive proof of its non-occurrence." So CDC sent out a letter in September of 2017 saying that U equals U, that HIV is not transmitted between sexual partners when the HIV positive partner is fully virally suppressed. There have been over 820 U equals U partners that have signed on from 97 countries. And there was a really wonderful presentation by Carrie Foote, a person living with HIV, to talk about how U equals U is a game changer, that it transforms social and sexual and reproductive lives, that it dismantles HIV stigma, that it encourages getting tested and starting and staying on treatment and in care, and it provides a strong public health argument for eliminating barriers to universal access to care. She also had some interesting words of wisdom to those of us who are clinicians in not undermining the U equals U message by being overly cautious. She said, don't say, "I believe in U equals U, but use a condom just in case." Instead, you might say, you might want to use a condom to prevent other STIs and unintended pregnancy, but condoms aren't clinically necessary to prevent HIV. She said, don't say you're only as good as your last viral load test. Rather say, if you're taking your medication as prescribed and getting your labs done regularly, don't worry. And it's really important to take this worry and stigma away from HIV transmission. And I see that there was one question about what's the HIV RNA threshold for sexual transmission, and this U equals U has been in studies where the threshold was 200. But what I would say is that in observational study early on in the epidemic in Uganda, the cut point was 1,500 Anyone with a viral load of less than 1,500 who weren't on treatment did not transmit to their sexual partners. But the myriad of studies that I cited used a cut point of viral load of 200. So one of the questions that gets asked is, well, how long do people stay virally suppressed? And this was data from a poster presentation of more than 1,800 HIV-positive patients at a hospital in Providence, Rhode Island. And what they found was that there was about 85% maintained viral suppression throughout the 2 years of follow-up. Each year, about 5% lost viral suppression, and about 10% didn't get a viral load measured. The independent predictors of losing virologic suppression were being at younger age and also not being retained in care. And so what that tells us is that we need to remember that younger people in particular may need closer follow-up, and that when people don't show for appointments, we need to be proactive in getting them back in for care, because otherwise they may lose viral suppression. So let's turn now to drug use, and there were actually a lot of presentations as well as a full seminar on drug use. This was from an oral presentation from the CDC looking at crude death rates per 100,000 persons with diagnosed HIV infection. And what they pointed out is that the good news is that total deaths have decreased over the last 4 years by 13%. So deaths from all causes have been going down. But at the same time, deaths from opioid overdoses have been going up. And you can see that the scale is different, but that there's been this 43% rise over the last 4 years in opioid overdose deaths among people living with HIV. Who is it that's most impacted by this? Well, you can see that the highest rates are in people who were infected initially through injection drug use, but also men who have sex with men who inject drugs also have very high rates of opioid overdose deaths. Both of those have increased over the last 4 years, as has increased those who were infected through heterosexual contact. The absolute number of opioid deaths is lower, but the proportion increase is quite high. You can see that all racial and ethnic groups have got increases in the proportion or the absolute death rate from opioid overdose deaths, with white individuals having the highest rates of opioid overdose deaths. And you can see that all of the regions except for the West have increased rates of opioid overdose deaths, with the highest rates in the Northeast. So data were presented from the ALIVE cohort of over 3,400 people who inject drugs in Baltimore, Maryland. They had over 111,000 person-years of follow-up. They had almost a 1% per year rate of overdose deaths that were more common in people living with HIV, in younger people, and in men. And they had really an astronomical 24% per year rate of non-fatal overdoses that increased in 2017 to 2018. It was more common with opiate use and any injection drug use. So that really reminds us that we need to do whatever we can to try to reduce opioid overdoses and opioid overdose deaths, including provision of naloxone to all of our patients who are prescribed opioids or who use opioids either through injection drug use or other means, orally or other means. And this was data from Washington, D.C., and you can see again this big rise in overdose deaths, accidental overdose deaths. So we saw this in presentation after presentation. We also looked at suicide rates among people living with HIV in the United States, and this came from the NA Accord data, and that was over almost 56,000 men who were living with HIV. And what you can see in this figure is that the red dots are white men, and the blue dots are black men who were part of the cohort. And that's superimposed on the red line, dotted line, are the rates of suicide in the general white population, and in blue, the rates of suicides in the black population. And what you can see is that white men with HIV had substantially higher suicide rates than in the general population, and that it's come down in black people living with HIV. But within the cohort, compared with black non-injection drug users, white injection drug users had 10 times higher suicide rates, 5.9 times higher suicide rates in white men who were not injecting drugs, and 2.2 times higher suicide rates in black injection drug users compared with black non-injection drug users. Suicide was relatively rare among the 21,000 women in this cohort. So suicide and treatment of depression is another important thing for us to be monitoring and treating in our patients who are living with HIV. These were data on predictors of suicidality in 11 U.S. cities, and again, injection drug use and alcohol use was associated with increased suicide rates, as well as being Latino, having a low CD4 count, no college, or low social support. So it just reminds us that we really need to treat depression in people living with HIV. What about HIV infection rates in people who inject drugs? What you can see on the top line, and this came from a poster in which there has been a 33% reduction in HIV new diagnoses from 2010 to 2014, but after that time it's leveled off. So we're not seeing that same decline now in rates of new diagnoses in people who inject drugs. And while we think of there being this rural epidemic, the HIV epidemic in opioid users is really, and people who inject drugs, is really in the urban areas. So all of these are urban areas or peri-urban areas. In the rural areas, the rates are substantially lower. So we do have this really substantial epidemic of HIV in people who inject drugs in urban areas. This was what I referred to earlier as these two cluster analyses that were seen in people who inject drugs. In Seattle, there was an outbreak. A DIS individual noticed 3 linked cases, went and investigated and started the Seattle Health Department went and started offering testing to sexual partners and other injection drug users, and eventually they found 15 linked cases among homeless people who inject drugs within a 3-mile radius in Seattle. And in Massachusetts, the health department identified 5 cases initially in people who inject drugs, and when they went to their injection drug partners and sexual partners, they eventually found 129 linked cases. So these are examples where identification of a cluster can allow health departments to go in and try to prevent further onward transmission through active treatment of people living with HIV and pre-exposure prophylaxis for people who are at risk of HIV acquisition. Let's turn now to talking about sexually transmitted infections. Dr. Jeannie Morazzo gave a really excellent plenary talk on STIs and asked first, why should we discuss STIs at CROI? And she pointed out these 2 infographics. On the left-hand side is the global epidemic, on the right-hand side the U.S. epidemic. And you can see that WHO estimated that last year, among adults 15 to 49, there were 376 million cases of curable STIs. That's chlamydia, gonorrhea, syphilis, and trichomoniasis. And you can see that it's really widespread globally. When we look at the United States in 2017, you can see there were 1.59 million cases of chlamydia. That was almost a 5% increase in the previous 2 years. There was nearly 500,000 cases of gonorrhea, which was almost a 20% increase over 2 years. And over 27,000 cases of syphilis, which was an 18% increase over the prior 2 years. And this is important because these diseases cause morbidity, like the reappearance of LGV proctitis. In syphilis, we've got levels now, and I'll show you in a moment, that are exceeding the levels that we saw before the AIDS epidemic in men who have sex with men, and it's spreading into heterosexual networks. And we also have issues with gonorrhea antimicrobial resistance, making it much more difficult to treat. So these are the syphilis, this is the syphilis slide, and you can see on the top are graphs for men, and on the bottom are graphs for women. what you can see is that the rate of new diagnoses, syphilis diagnoses, peaked in the late 1980s, just at the time of the epidemic, and then, in the early 1980s, just before the epidemic. And then when HIV was recognized, sexual practices changed substantially, and we had a really substantial decline in syphilis rates, but it's been increasing since the early 2000s, going up, and you can see that it's continued to climb from 2013 to 2017. 88% of cases are occurring in men. 80% of those are in men who have sex with men, and half of those are in men who have sex with men who are living with HIV. So we have a really substantial syphilis epidemic in men who have sex with men. But we're also seeing this bleeding into the women's population, where we've got a 156% increase in primary and secondary syphilis compared with 2013, and a 154% increase in congenital syphilis, which should be completely preventable. 918 cases of congenital syphilis in the last year. In California, over half of the cases were women who did not have prenatal care, so it's really important to get pregnant women into prenatal care, and there's been a strong link with this congenital syphilis to meth and heroin use in women. In terms of gonorrhea and chlamydia, these are the rates you can see up above in men who have sex with men in the black line. Sorry, I'm trying to get that pointer back, but I don't see it. And if you look over on the right-hand side, you can see that a lot of the gonorrhea and chlamydia and it's stratified by HIV negative on the left and HIV positive on the right, but the different colors, rectal GC in green, rectal chlamydia in yellow, pharyngeal GC in red, pharyngeal CT chlamydia in blue, that many of these cases are asymptomatic, but they're extragenital, and so it reinforces the need to do 3-site screening for STIs, to do pharyngeal swabs and to do rectal swabs to detect asymptomatic infections with gonorrhea and chlamydia and to treat them. And what you can see on the bottom is that there's been this international spread of gonococcal resistance to ceftriaxone, and particularly when it occurs in concert with high-level resistance to azithromycin, you need to use other antibiotics, and we really have very few options available. So this is a very serious epidemic and one that we need to try to find ways to control. This is a map of the ceftriaxone on the left and the azithromycin on the right resistance, and what you can see is that ceftriaxone, almost a quarter of the countries that report on resistance have detected some ceftriaxone resistance, and in 7 countries they have greater than 5% resistance. The blue are the ones that have no resistance, but all of the non-blue colors are countries that have resistance to ceftriaxone reported. And if you look at azithromycin, it's a much more dire situation where 81% of countries have reported azithromycin resistance to gonorrhea, and 30 countries have more than a 5% rate of resistance to gonorrhea. So what Dr. Marazzo recommended was that we need to deploy rapid and accurate diagnostic tests for STIs in high-incidence settings, particularly in some developing countries where they use syndromic management. We really have to move away from that and get screening with diagnostic tests, because many of these infections are asymptomatic and yet they cause substantial morbidity. We need to enable point-of-care tests and detection of antimicrobial resistance. We need to ramp up STI screening in asymptomatic people in both HIV care and prevention, and that's really important that we be doing quarterly screening in people living with HIV if they're sexually active with multiple partners, and people on pre-exposure prophylaxis, but others who aren't on PrEP but have multiple sexual partners or who may be at risk. We need to be doing this 3-site screening or site-specific testing, particularly for people who have oral or anal sex. We need to expand partner management strategies, address supply chain challenges. There's some problems with supply of benzathine penicillin. We need to invest in vaccine and therapeutic research and development and recognize this syndemic of HIV and STIs. So these were data, and I'm trying to get my pointer back, but I don't seem, oh, there it is. Let's try it again. I don't seem to be able to grab it. But at any rate, if you look at the two lines on the top of this graph, this is from the Boston Fenway Health Center, and all men with at least one STI between 2005 and 2015. And the question that's been asked is there a, are we seeing increases in STIs simply because we're doing more screening now, or is it that we're actually seeing more STIs because there are more STIs? And so if you look on the top, those are the screening rates of gonorrhea shown in the circle and chlamydia shown in the triangle. But in the bottom are the positivity rates shown in the circle and the triangle. And what you can see is that while screening rates have certainly gone up over time, so have the rates of positivity, the proportion of tests that are positive. So that would imply that this is not just a result of increased screening, but that we are truly seeing increases in sexually transmitted infections. And in this particular study, they found that the STI rates were highest in HIV positive and PrEP users. These are data from the HOPS study, the HIV outpatient study, and they had over 4,700 HIV positive people. On the left are the men who have sex with men. On the right are the non-men who have sex with men. And what you can see here is that the screening rates are shown in green at the top and the positivity rates in red at the bottom. And again, you're seeing this increase in screening, particularly in men who have sex with men, but somewhat also in non-men who have sex with men, but also an increase in the positivity rate, particularly in men who have sex with men. What was important here was that the rates were highest in young men, men who have sex with men, and individuals with prior STIs. Most of the gonorrhea was rectal and or pharyngeal, so again, asymptomatic and requiring that there be 3-site screening for men who have sex with men. And importantly, half of the men who have sex with men had no testing in the prior 12 months. So this probably underrepresents the true rates of STIs and really reminds us that we need to be getting quite frequent STI screening in at-risk populations, particularly people living with HIV. So we're going to turn finally to pre-exposure prophylaxis, and we'll start with the DISCOVER trial that many of you, that we asked the initial question about at the beginning, and many of you got right. The DISCOVER trial was a randomized non-inferiority trial of FSTAF, or FTC with tenofovir alafenamide. The reason for studying FSTAF, we have a perfectly adequate PrEP tool right now, FTDF, or emtricitabine co-formulated with tenofovir, and the only challenge is that we know that there's a modest reduction in bone mineral density, probably not clinically significant, but it also can only be used in people who have a GFR of greater than or equal to 60. And it does cause a very small reduction in GFR in some individuals, generally reversible. But the question is, what would FSTAF do? Could that be an effective pre-exposure prophylaxis method? And so what was done was they took nearly 5,400 or over nearly 5,400 men who have sex with men and transgender women and randomized them to receive either FSTAF or FTDF. They then measured the HIV incidence rate in these individuals. And what they did was took people who had 2 or more condomless anal sex acts in the past 3 months, or rectal gonorrhea, chlamydia, or syphilis in the past 6 months. They had to be HIV and Hep B negative, have a GFR of greater than or equal to 60, and they could have been using PrEP previously. They conducted the study in 94 sites in 11 countries, and most of the participants came from the U.S. The majority, 60%, came from the U.S., but 34% came from Europe and 7% from Canada. And their primary efficacy endpoint was to have a non-inferiority margin of greater than 1.62. Of less than 1.62. So that meant that it had to be at least no more than 1.62 times worse than tenofovir FTC in order to be determined to be non-inferior. The population they recruited was not completely representative of the population of people getting newly infected. As I said early in the webinar, we know that there's an intense epidemic, particularly in African American men who have sex with men, and here only 9% of the population were black, and only less than 2% were transgender. So we don't have a lot of data then on transgender individuals. You can see the rates of risk at the beginning, and they were fairly evenly balanced between the two arms. Here's what they saw in terms of numbers of infections. So there were 7 infections in the FSTAF arm, 15 infections in the FTDF arm, a point estimate of 0.47, but the 95% confidence interval did include 1, so that meant that it was not superior to FTDF, although that wasn't really what the study was intending to look at. It was intending to be sure that it was non-inferior, and it was lower than the non-inferiority margin, so we're able to say that FSTAF was non-inferior to FTDF in prevention of HIV acquisition when used as PrEP, as daily PrEP. The Discover study also reported on the number of new infections in the two arms and what the characteristics were. And you can see in the black bars over on the left that there was 1 infection in the FSTAF arm and 4 infections in the FTDF arm who were actually already infected at the time that they enrolled in the study. It's just by chance that they were unequally distributed between the two arms, but these were individuals who were antibody negative but found to be NAT positive on follow-up testing. In the hatch marked bars, you can see that the majority, 5 infections in the FSTAF arm and 10 infections in the FTDF arm, had low levels of drug available in their blood. So that's presumably why those individuals were not protected. And there was only 1 individual in both arms that had medium or high levels of drug in their blood who became HIV infected. So of course, one of the natural questions to ask is, well, what about resistance to antiretrovirals? Were these resistant strains that they became infected with? And in fact, what was seen was that there were 4 infections that had FTC resistance and none that had tenofovir resistance. And the 4 that were infected that had FTC resistance were people who were already infected when they enrolled in the trial in the FTDF arm. So these are individuals who presumably developed FTC resistance because they were being effectively treated with the 2 drugs, FTC, tenofovir, which is inadequate treatment for infection because it was unrecognized that they were infected when they entered the study. What about bone safety? Well, as you can see in the gray bars, the proportion, the reduction in bone mineral density is about 1% in both spine and hip in people getting FTDF. There was a slight increase in bone mineral density in the people who got the FSTAF. And if you look at the people who had greater than a 3% decrease, it was 27% in the FTDF arm and only 10% in the FSTAF arm. What I'll say is that from earlier studies, both the the clinical trials as well as observational studies, we're not seeing clinically relevant reductions in bone mineral density. But still, I suppose if you have a patient who has known osteoporosis, you may want to be considering FSTAF as a potential PrEP agent in lieu of FTDF. I will say that it's not yet approved for this use, but that Gilead has filed with FDA for this indication, and so we hope to hear within the next 6 months or so. This is the renal toxicity slide, and you can see that while there's again a very minimal reduction in GFR of 2 milliliters per minute in the FTDF arm, where in the gray, whereas in the green it's an increase of about 2 milliliters per minute. So again, what's helpful is for people who have GFRs of less than 60 who are not able to take FTDF, this may be a viable alternative for those individuals. And you can see that in terms of renal discontinuations, there were 2 in the FSTAF arm, 6 in the FTDF arm, and Fanconi syndrome, there was only 1 in the FTDF arm. So moving on to new PrEP agents. Right now we only have one game in town, and that's FTDF. Maybe it will become FSTAF as well, but there are other agents that are being tested. There's long-acting cabotegravir, there are implants and that are about to be tested, and long-acting oral agents and so forth. But this was data on a new way of administering PrEP, which is topically using an insert. What they said is that you could use this as targeted drug delivery in the right place at the right time, that it's small, discreet, and easy to carry. It's self-administered, so you don't need an applicator. There's minimal leakage, and you can use it for either vaginal or rectal sex. It would have a favorable safety profile in that you don't get systemic drug exposure in using these topical agents, and it might allow for more flexible dosing options. And Conrad is developing inserts containing tenofovir, alafenamide, and elvitegravir for topical HIV prophylaxis. And they presented data on a non-human primate vaginal challenge model where TAF elvitegravir resulted in, as a vaginal insert, was 92% efficacious in preventing SIV or SHIV acquisition in these animals compared with the placebo. So more to follow on this, but I think that the entire field of long-acting injectables, implantables, inserts are all being developed, and we should have hopefully more options for PrEP in the not too distant future. What about use of the agent that we currently have available? We know that PrEP awareness has been low previously, and these are data from the NHBS, or National HIV Behavioral Surveillance surveys that occur in men who have sex with men every 3 years. So this is comparing data from 2014, shown on the left of each of these clusters in the lighter bars, with what was seen in 2017 in the darker bars. And what we can say is that there's been an overall increase in PrEP awareness from about 60% to about 90%, which is great. And while it looks like there are these racial and ethnic differences, and there were previously, that after you control for income, census, and insurance, this is all on the top bars, there's no significant difference. The bottom bars are showing sorry, I'm not able to grab this arrow, but the bottom bars are showing PrEP use. And here we've gone from 6% overall use to 35% overall use within the NHBS. So that's a great increase. And remember that we're trying to target 50% of people who might be eligible for PrEP as the target that HHS is setting out for nationally. Unfortunately, here we're not seeing the same increases in all racial and ethnic groups, and in particular, black men who have sex with men after controlling for income, census, and insurance had lower rates of use than other racial and ethnic groups. So it again reminds us that we need to be doing more to try to get PrEP uptake increased in communities of color. There wasn't very much presented on women and PrEP, but this was a survey of 370 women in Chicago. Only 30% had heard of PrEP, so contrast that with the 90% of men who have sex with men who had heard about PrEP. Of these, 38% met criteria for PrEP, and of those, 29% were interested in starting PrEP. So we have a lot of work to do in both getting knowledge and awareness of PrEP up in women, in populations of women, and getting increased interest in PrEP in women who may qualify for PrEP. This was really interesting data on same-day PrEP starts. And one of the things that we know is that if you do your screening for PrEP and you require that people come back, they may or may not come back. And that may be particularly true at sexual health clinics. So these were data from the New York City sexual health clinics. They had over 1,400 potential PrEP candidates, and they queried them, do you have any kidney disease? Do you have a history of chronic hepatitis B infection? Do you have any signs or symptoms of acute HIV infection? If the answer to all of those questions was no, then they went into the immediate PrEP arm shown on the left. That was 97% of people were able to qualify for same-day PrEP starts, immediate PrEP. If they said yes to any of them, then they were put in the delayed PrEP arm, and they first got the results of the test before they offered PrEP. And so what happened in both of the arms? Well, in the left arm for immediate PrEP, the only absolute contraindications to PrEP were having a GFR of less than 60 or having already being infected with a NAT positive result. And what they found was that there were 2 people who had low GFRs, 2 people who were NAT positive, so they had to stop PrEP in 4 individuals, but that's only 4 of 1,387, so that's less than 1% did they have to stop PrEP, and they were able to stop PrEP within 10 days. In the delayed PrEP arm, they had to stop PrEP, they couldn't start PrEP in 7 individuals, that was 14% of that group. But of the 86% who were eligible, only 35% of them actually came back and started PrEP within 2 months. So it does sort of speak to this bird in the hand idea that when you get somebody in clinics where you may not see them regularly, requiring that they come back for their test results before starting PrEP may present a barrier to PrEP starts. And this suggested that at least with these 3 fairly basic questions, that you could get pretty safe PrEP starts in over 99% of individuals who qualified for PrEP. We also need new methods of delivering PrEP, and this was data on a TelePrEP model called ePrEP that was delivered to 18 to 35-year-old black men who have sex with men in rural Georgia and Mississippi. In this situation, 50 men who have sex with men received home test kits for home collection of STI and HIV specimens, and they had to get rectal swabs, urine, and pharyngeal swabs, and then also to do a finger prick to get their HIV test and syphilis testing. 50 men received the test kits, half of them completed their telemedicine visit, and 21 picked up their PrEP prescription. And over on the right, you can see the acceptability of these various approaches. So in the green are acceptable and very acceptable, in the gray is neutral, and in the red is either unacceptable or very unacceptable. And you can see that the urine specimen collection was very acceptable, and even the rectal swab collection, except for in 1 person, was very acceptable. The finger prick was a little bit less, people were a little bit less excited about that. But the telemedicine, in terms of the telemedicine portal, both text messaging and video were highly acceptable. And so in most, 93% were willing to use ePrEP in the place of a standard provider visit. So people who ended up using this, only half of people actually completed the telemedicine visit. But of that group, 93% were willing to use ePrEP in the place of a standard provider visit, and the majority, 2/3, were likely to remain on PrEP, said that they would be more likely to remain on PrEP if ePrEP were available. Importantly, only 9 individuals after the study was over linked to care. So this again speaks to the challenges, the structural challenges that may occur, particularly in rural settings, for individuals to access PrEP, and so we need some of these novel strategies for PrEP delivery in those settings. PrEP persistence in privately insured and Medicaid patients, there was a commercial database with over 700 PrEP users and a Medicaid database of nearly 350 PrEP users. What they found was, in comparing across the two databases, that persistence or staying on PrEP over time was longer in the privately insured than in the publicly insured group, although it was just over a year in the even in the privately insured group. And what we know from a myriad of examples is that there are people who are not staying on PrEP and become HIV infected. When they did multivariable models, younger age and female sex came up as being important in both the privately insured and Medicaid patient examples for being less likely to be persistent, living in rural areas for privately insured, and Black race for publicly insured were less likely to stay on PrEP. This received some attention. What the group was trying to do was to see, what about people who were on PrEP who become infected? Do they have resistant virus? And so what they did is they looked at 3685 people who were recently diagnosed in New York City. Only 2% of them had previously used PrEP. However, of that 2% who had been previously on PrEP, 29% had an M184V or related mutation, meaning that they were resistant to the emtricitabine component of emtricitabine tenofovir of PrEP. And it's likely that most of these individuals were HIV infected when starting PrEP, so they wanted to look at, well, did they have NAT testing, which is recommended by the New York City Department of Health for anyone who's got either symptoms or who has had condomless anal sex or condomless sex in the last 4 weeks. And they found that only 5% of those individuals who later became infected had had a NAT test when they started. And so the bottom line take-home message here is that it's really important to do NAT testing at the start of PrEP to be able to detect early HIV infection before resistance develops, because if you start somebody on PrEP who's already HIV infected, resistance will develop over time. These were data on aberrant results that we're seeing sometimes in people who are on PrEP. This was a case of a false positive test result, and what you can see is that this was somebody who was using on-demand PrEP, who was highly adherent, had been getting fourth-generation HIV tests. They were negative, 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 and then in June they tested using a different fourth-generation test kit, and it became positive, but they were negative by viral load and negative on Western blot. They had a P24 band. When they went back and tested using the original fourth-generation test, that was also negative. And so the question was this truly an early infection with a suppressed virus because they were on PrEP, or was this a false positive fourth-generation test? And what they found was it was a false positive fourth-generation test. The Western blot did not evolve. They went off of PrEP, and they remained undetectable, but they still had this persistent false positive test result on the Architect fourth-generation test. And so this was a really great talk by Jean-Michel Molina, and I would highly recommend that presentation, that webinar as well. And what you can see here, and I don't think I have my pointer back, but if you look at the top, generally the RNA is going to turn positive before the P24 antigen in a fourth-generation test. And what we're seeing sometimes is an aberrant result where you have a negative viral load but a positive fourth-generation test, and that can be due to either a a positive, either if somebody is actually infected but virally suppressed, or if they've got a false positive test. So what he did is he went through these ambiguous and discrepant results and talked about there are three options that you have. You can, on the left, continue PrEP if you're adherent. The challenge there is if somebody's truly HIV infected, they may remain virally suppressed for a while, and you risk the development of resistance. On the far right, you could start antiretroviral treatment, particularly if they were not adherent to PrEP, thinking that this represents a true infection. The problem is that you do at some point need to confirm diagnosis because you don't want to commit someone to lifelong antiretroviral treatment if they're not actually infected. The third option in the middle is to stop PrEP and reassess the HIV status, but in this situation, it will help you, it will facilitate the diagnosis, but you need to make sure that people remain safe and are not at risk of HIV acquisition by using condoms and clean needles and so forth. And what Dr. Molina recommended was that people who have these aberrant results on testing contact the PrEP warm line. Then the phone number is shown here. It's open from 11 to 6 Pacific time, and they will talk through with you what it is that may need to be done in order to sort things through. And then the final slide is just in IPERGAY, fewer pills had less renal effect. So that's just, again, to say that when people use on-demand PrEP, they may be getting less PrEP exposure and they may have less renal impact. But again, even those who had the highest level of drug in their blood had a decrease in their GFR of only 2 milliliters per minute. So that's the end of the webinar. We're going to ask these post-test questions, so please answer these. Which statement is true of a person living with HIV who's fully virally suppressed? One is they can't transmit HIV through breast milk. 2 is they can't transmit HIV sexually. 3 is they can transmit HIV sexually if they have an STI, and 4 is they can transmit HIV through anal but not vaginal sex. Okay. And I will tell you that 90% of you got this right. They cannot transmit HIV sexually. Even if they have STIs, we're not seeing transmissions occur. Okay, next question. Which statement is true of TAF-FTC? It's either 1, superior to TDF-FTC in efficacy as PrEP, 2, it's inferior to TDF-FTC in efficacy as PrEP, 3 is it's associated with a more favorable renal profile than TDF-FTC when used as PrEP, and 4, it's associated with more antiretroviral resistance than TDF-FTC. Okay, so 96% of you got this one right, and it's associated with a more favorable renal profile than TDF-FTC when used as PrEP. It's non-inferior, which means it's not either inferior or superior. It's not any worse than TDF-FTC. Okay, let's turn to answering some of the questions that came up. There were a couple of questions about, and please type any remaining questions that you have into the chat box. There was a question about the availability and affordability of FSTAF as opposed to FTDF, and I think that that's a real concern. My impression of this at the moment is that FSTAF may be used in people who are not able to take FTDF for particularly because of renal disease or concerns about renal disease. But I think it remains to be seen whether FSTAF will replace FTDF as PrEP. particularly because FTDF is will be substantially less expensive when it goes generic. And right now, FSTAF is not yet approved, so it may not be covered as PrEP at the moment. So just something to watch out for. There was a question about what causes the increase in bone mineral density in the FSTAF arm. I don't know that that was anything other than noise in the system, but because I don't think that we would say that FSTAF actually increases bone mineral density. It was a really minor increase in bone mineral density over time. Someone asked a question about PrEP being taken, how long it needs to be taken for. So for pre-exposure prophylaxis, you need to take that during periods of risk. And one of the questions that arises is, how long before sexual exposure do you need to start PrEP? And I think that there's some controversy among the pharmacologists about how this should be viewed. What CDC says is that men who have sex with men need to take this at least 7 days before they achieve steady state, so that would be because FTDF concentrates more quickly and at higher levels in rectal tissue than in vaginal tissue. So 7 days for men and 20 days is what they say for women. What I would say is that what we know for men is that 2-on-1 PrEP or on-demand PrEP, where you take a loading dose of 2 pills 2 to 24 hours before sex, 1 pill 24 hours after that, and another pill 24 hours after that, is highly effective in preventing HIV infection, as shown in the IPRGACE study, and has been now shown in some demonstration projects after that. So it would suggest that you don't need 7 full days of PrEP in order to achieve protection in men. And for women, I think pharmacologists are saying probably 7 days gets you to high enough levels for protection, and it may be less than that. So I think it's hard to know for how long before. I think that that's what the question is how long do you need to take PrEP before it becomes effective. You need to then continue taking PrEP throughout your period of risk before stopping PrEP. And I don't think that we know, what CDC says is that you need to take PrEP probably for 28 days after your last exposure in order to be protected. But again, knowing what we know about on-demand PrEP, which we only know these data for men who have sex with men, it's not something that should be recommended for either women, cisgender women or transgender women. But for men, what we know is that a dose 24 hours later and a dose 24 hours after that appears to be sufficient in preventing HIV acquisition. We have a question about how do you calculate PrEP persistence when some people may stop PrEP at any time when they're not eligible, so if they change their sexual activity. This is a really challenging issue. It's absolutely true that when we talk about PrEP persistence, it's not the same as talking about antiretroviral treatment, where people need to stay on treatment for life. For PrEP, you only need to stay on during periods of risk. And so the question is, how long is that you need to stay on? How do we measure that when we don't know if somebody's going off of PrEP because they're truly no longer at risk, or because they think they're no longer at risk? And we certainly hear cases of people saying, well, I had 40 partners last month, and now I only had 20 partners, and therefore I don't need PrEP anymore because I've really cut down on my risk. And obviously that's somebody who would still benefit from PrEP. All I can say is we don't have a good way of measuring that in these persistence studies. But what we do know is that there are many cases that have been reported now of individuals who stopped PrEP either because they thought that they were no longer at risk, or because of systemic kinds of structural challenges with getting their prescription, getting into the doctor, getting their lab tests done, getting insurance to cover it, and who have become infected. So it's a challenge for our studies, but we really do need to, if we have patients on PrEP, talk with them about why they're going off PrEP and make sure that it's for good reasons. There's a question about how forgiving is FTC-TDF with regard to missed doses, and that is, it's fairly forgiving for men, again, because you get higher levels in rectal tissue and in rectal tissue than you get in vaginal tissue. So we know that 4 doses a week is roughly equivalent to 7 doses a week for men. So what I say to male patients is, you know, it's good for you to try to take your PrEP, if they're on daily PrEP as opposed to on-demand PrEP, it's good to take the pill every day. If you miss a dose here or there, it's not going to matter so much. For women, we think that 6 to 7 doses a week is what's needed in order to stay, to maintain the highest level of efficacy. We don't really know about forgiveness with FSTAF. We assume that it's going to be comparable, but we don't have data on that quite yet. I have a question about why would PrEP be expected to be ineffective for trans women? So PrEP is effective for trans women, we expect. We think it is. In the IPREX study, there were a small number of trans women. The only women who became infected, trans women who became infected in that study were women who had no detectable drug in their blood. So we do think that it's effective in trans women. There have been some studies to try to figure out, does PrEP interfere with hormone levels, and do hormones, for gender-affirming hormones, do they interfere with PrEP levels? So what we know to date is that it does not appear that PrEP lowers trans-affirming hormone levels. So that's good news. It does look like there may be a very modest reduction in tenofovir levels in transgender women. Not enough to affect efficacy, we don't think, but we don't know that it isn't, we don't know that PrEP, that on-demand PrEP, for instance, works for trans women, and what we would say is for cis and transgender women, 6 to 7 doses a week will probably maximize efficacy, whereas for men, 4 to 7 doses a week is what maximizes efficacy. We have a question about when will FTC TDF likely go generic. I think there are generic manufacturers now, but it's not widely available. I think within the next couple of years we should have hopefully a reduction in price in TDF, but not FSTAF. Is there any information about FSTAF being used in PEP cases? Not that I'm aware of at this point. And there was a reminder from one of the audience members that I really appreciate, that Hep C treatment and testing is really important for people who inject drugs. So while we were talking about other STIs and not hepatitis C, hepatitis C can be transmitted sexually, but it's certainly transmitted through sharing of injection equipment. And so we really do need to do Hep C screening and treatment for people who inject drugs. And I think there's a question about when we should worry about GC resistance when screening is using NAT. And I do think that we don't yet have high levels of ceftriaxone resistance in the U.S., but if somebody has a gonorrheal infection and they don't have a test of cure, then I think you'd want to get resistance testing in that situation to be sure that that they don't have resistant gonorrhea. There's a question about using TDF3TC for PrEP because that you can get at a much lower cost. We don't have data on it, but we should expect that it would work. So I think that it's a provocative question, and one that's an important question, and one that may in fact be a reasonable, it would be a cheaper version of PrEP, and so I think that that should be a reasonable option for individuals. Let's take this last, let's see. Is there any new information on PrEP to be more affordable? Okay. I think that there will be, hopefully, so I think that there's this TDF3TC as an option for PrEP, and I do think that we'll get more generics of TDF-FTC available in the near future, and so I do think it will become more affordable. So with that, I'm going to end the question session and just give you a couple of more pieces of information. The webinar is going to be available for on-demand viewing and CME credits at this website, at the IAS-USA website. You can see instructions for claiming your CME and pharmacy, nursing, or pharmacotherapy credits or certificate of participation by visiting the website. There are some upcoming webinars. I mentioned the one from Timothy Wilkin on Tuesday, May 21st, but there's one coming up next week on management of strategies for sexually transmitted infections. So please visit the IAS-USA website regularly because there are a lot of really great webinars that are happening. There are also great courses. There's one in Washington, D.C., one in L.A., and